A very good morning, afternoon, and evening to everyone tuning in from around the world. Welcome to ACOP 2022. I'm Chi Ching, a psychologist with the Ministry of Home Affairs, and I'll be your facilitator for this special session on drug harm prevention. I'm very excited to know that we have friends joining us from all parts of the world, not just from Singapore. And that's the beauty of a virtual conference. So once again, thank you for being with us. As a gentle reminder to all our colleagues and delegates with us on this session not to record or reproduce any content from the presentations that will be screened on public platforms, for instance, social media. Nevertheless, for non-sensitive content, you're free to and encouraged to share your experiences and thoughts on our social media. Don't forget the hashtag ACOP 2022. Delegates can also find the recordings of the conference presentations on this platform after the day's proceedings have ended. For this special session today, we have a total of 3 presentations, with each presentation lasting a total of 15 minutes. Our speakers are live with us, and they'll be taking questions from the audience in the combined 10-minute Q&A portion at the end of this special session. Again, we strongly encourage all attendees to post any questions or comments that you may have for the questions via the Q&A tab. Without further ado, let me introduce the first presenter for this session. Dr. Kandasamy is a senior consultant psychiatrist and chief of the National Addictions Management Service, which is part of the Institute of Mental Health Singapore. He has a keen interest in treating alcohol, substance, and behavioral addiction patients. He also has impeccable clinical experience in the field of adult mental health. Today, his talk will focus on the scientific evidence for the effectiveness of harm reduction approaches so far and the pitfalls in relation to opioid use disorder, and explore whether such approaches are applicable in the local treatment setting. We'll now start the presentation by Dr. Kandasamy. Thank you.
Hello everyone, I'm Dr. Kandasamy from National Addictions Management Service, Singapore, and I'm going to give you an overview of pros and cons of harm reduction approach for opioid use disorders based on a brief literature review in the next 15 minutes. People with opioid dependence are currently estimated to be around 27 million, and half of them reside in Asia. It is a chronic and relapsing disorder. Clients can cycle in and out of active OUD with multiple exposures to treatment, incarceration, and abstinence over many years. They do present with increased criminal activity with huge economic cost to the society. If left untreated, many users develop mental and physical health problems, carry high risk of infection with HIV and viral hepatitis, and died due to unintentional drug overdose and suicide. Pharmacologically, methadone and buprenorphine are the 2 common medications given in harm reduction approach. Naltrexone is an opioid antagonist with a focus on achieving total abstinence. Medical heroin is given in countries such as Germany and Switzerland. Non-pharmacologically, inpatient detoxification is a common one, followed by outpatient-based rehab programs. Other methods are prison-based rehabilitation, therapeutic community, and self-support groups. What is the rationale for harm reduction strategy? The harm minimization approach accepts that the drug use will continue to be part of our society. The eradication of drug use is made impossible, and continued attempts at eradication may well result in increasing harm to society. People say it is based on pragmatism and humanistic values, and the main objective is to reduce adverse consequences. It emphasizes measurement of health, social, economic outcomes as opposed to the measurement of drug consumption in terms of achieving abstinence. And it is based on a comprehensive public health framework and built on evidence base. And it has evolved over a period of time from the initiation in the 1980s. And OST remains the most common form of harm reduction treatment, with needle exchange program also is another key part of the strategy. An estimated around 655,000 people are currently registered in Europe alone to receive treatment, and typically they receive treatment for more than 2 years. The main aims are to establish psychosocial stability by reducing the illicit opioid use, reducing the incidence of injecting and sharing equipment, reducing the use of other street and prescribed drugs in the shorter term, and in the longer term to increase the chance of abstinence from all drug use. What has the harm reduction treatment achieved so far? Well, methadone has been in use for more than 40 years now, and it is used as a substitute instead of heroin, mainly because it can stop the craving, withdrawal, and the binge cycle of heroin due to its longer duration of action, and also it won't produce the same highs as heroin. High methadone doses, multiple and longer cumulative treatments are generally associated with more favorable outcomes, and it needs to be given in specialist settings. Buprenorphine is now prescribed as Suboxone, which is a partial agonist-antagonist combination, which seems to be superior to methadone because of its better side effects profile, low risk of overdose and recreational use, and also ease of use. And so it is a good option to use in outpatient and primary care settings. Several randomized controlled trials or RCTs, systematic reviews, meta-analysis, observational and long-term follow-up studies, including few textbooks have been published about OST's efficacy as a treatment during the last 3 decades. Whether it comes to increasing retention in treatment, reducing illicit drugs, use of illicit drugs, reducing risky injecting behaviors and eliminating HIV new infections, or reducing mortality or increasing life expectancy, or reducing years of life lost due to morbidity, improving physical health outcomes, reducing the social cost of heroin, reducing the criminal activity and imprisonment, OST has got the best evidence compared to any other treatments according to scientific research at the moment. The most reported benefit was stability and normality with improved capacity to fulfill as a role as a parent, family member, and friends. And in fact, WHO recommends methadone and buprenorphine as first-line treatment for OST, and also it is shown to be very cost-effective. How about pitfalls? Well, generally people do not want to talk readily about pitfalls as opposed to how they want to highlight efficacy in academic meetings according to my own little observations. Well, both legitimate and illegitimate ways of diversion and misuse is very common, and which can pose a huge public health concern. How do they do it? They can remove all part of the dose for self-medication. They can inject excess supply. They can save the dose for later use. They can trade between friends and family for money. And the diversion can also happen through faking opioid dependence and prescription forgery. And this particular type of prescription forgery or doctor hopping can happen in countries with fewer regulations. And drug dealers are another common source. It can be diverted in prisons. And generally, lack of OST programs and suboptimal prescribing practices are reported to be some of the reasons for misuse. Latest European drug reports say that large quantities of buprenorphine and methadone were seized from countries like Sweden, Finland, and Greece in Europe alone in 2017, which indicate that the trafficking and diversion at the retail level is not negligible. And most of the time, the trafficked OST medications originate mainly from the domestic supplies. Now, the demand for specialist treatment related to the misuse of OST medications is actually on the rise worldwide, and it is a big concern in Europe too. 2 out of 3 treatment entrants for primary methadone misuse reported having been in OST before in Europe. 22% of all clients entering specialized drug treatment services in Europe sought treatment for problems with OST before. Almost all countries report more and more people are seeking treatment for misuse of OST. And in Germany, more people with methadone misuse seek treatment. And in countries like Sweden and Finland, more buprenorphine misuse people are seeking treatment. And also, it is reported that those who seek treatment for buprenorphine are most likely to be injecting buprenorphine. When Suboxone as a combination product was introduced many years ago with the intention to reduce the abuse of buprenorphine, soon after that, Australian studies reported misuse of Suboxone too. So even Suboxone was not found to be 100% safe when it comes to OST treatment. With the misuse, the number of deaths associated with OST have been increasing over the past decade across the world. 2019 European Drug Report says methadone and to a lesser extent buprenorphine are among the non-heroin opioids which are regularly found in toxicological reports apart from heroin. As you could see from the data that I shared from countries such as Finland, Germany, UK, US, and Norway, all suggest that many of the overdose deaths were related to misuse of methadone and buprenorphine. And most of those people were not in OST treatment at the time of death, which means diversion was the main contributory factor. What are the other pitfalls? Well, the children from those who seek OST treatment have now been reported to have died due to taking overdoses. And individuals who inject buprenorphine are also put at risk of contracting blood-borne viruses again. Misuse increases crime, increases stigma, which further results in poor adherence to treatment. Misuse inside prison causes bullying among inmates. The indirect impact of misuse is decreased quality of life. High attrition rates with 40 to 60% drop out within the first year because the treatment is limited by the need for daily commitment from patients and specialist clinicians. Almost all patients in OST report high rates of relapse despite successfully completing treatment after discontinuation. And this raises the serious question on when to stop OST. And overall, the abstinence rate is about only 30% at 10 years follow-up with OST treatment. And extended OST causes clients to lack aspirations to quit according to studies. And many of them actually continue to use alcohol and other drugs despite successfully stopping opioids. Let's look at the efficacy of non-OST treatments. Well, to summarize, it is not great either. 91% relapse after detoxification and 60% relapse after 1 week and 70 to 90% relapse after 36 months. You know why? Neurobiologically, the neural adaptation that can occur in response to chronic heroin exposure, they are not immediately reversible after detox. Residential supervised withdrawal still associated with poor treatment outcome in the medium to longer term. Forced periods of abstinence such as incarceration are often followed by relapse with increased risk of both fatal and non-fatal overdoses soon after release, mainly because of loss of tolerance to opioids. And therapies like CBT, coping skills training, MI, self-help groups, peer support, all these interventions are endorsed by various national agencies, but the availability of evidence supporting the efficacy varies widely. And these approaches, generally, they do not have the extent of the robust evidence that one could commonly see with OST, and they are mostly considered for the potential synergistic benefit. Oral naltrexone, still high dropout rate, despite pharmacologically being an effective treatment. To summarize, despite being well delivered and having sound evidence base in overall reduction in harms and achieving stability in short to medium term, the negative impact of misuse and diversion of OST medications, including a broad range of negative outcomes for the individual and for the society, they are not just small problems to solve, they are indeed very significant. There is a consensus that harm minimization approaches may be neglecting to focus on a range of outcome domains that are required to improve the quality of life for heroin patients in the longer term. There is also a lack of documented evidence of the quantitative impact of misuse and diversion, especially with regards to quality of life of those misusing OST medications. Also, there are no clear definitions in the existing strategies in quantitative terms to support a significant change in treatment delivery and care by addressing misuse and diversion. To add on, the uncertainties in assessing and responding to diversion and misuse may be a key factor deterring physician participation and even some countries' participation in OST program. Diversion has threatened the reputation of treatment services and has compromised public acceptance of OST. Certainly, further research is needed to better understand the drivers and to define strategies that can effectively reduce misuse and diversion. Experts also note that prescribing more abuse deterrent forms of medications could serve as one intervention among others within the OST system to potentially increase quality, acceptance, and access to treatment. And certainly recent advances in pharmacological treatment options, which includes depot and implant formulations which can offer a longer duration of medications and thereby can reduce the risk of abuse and their impact on the longer term course of opioid addiction remains to be seen. To conclude, it is a big challenge to treat opioid use disorder clients considering the chronicity, variations in vulnerability and risk profiles, long-lasting brain changes, comorbid issues, and various social and legal problems that they face. Despite having good evidence in reducing harms, without addressing the problems associated with diversion, one cannot be very confident of its all-round success. There is also a lack of robust evidence from non-OST based psychosocial interventions as well. Other big challenge is how do you bring together all the relevant parties to address OUD at a public health level, as political and professional attitudes to scientifically established OST are highly variable between countries and even within countries. Also, little clarity on the concept of recovery. Wider definitions of recovery support the concept as a process rather than an endpoint like achieving abstinence. So, despite highly evidence-based treatments are available for more than 40 years, there is still uncertainties exist with regards to what is the best approach to treat OUD patient. So more research is needed as to how we can combine these two approaches together, the harm minimization and abstinence based, to achieve more meaningful outcomes for our patients. Finally, should we consider harm minimization approach in Singapore? Well, to answer this, perhaps we should look at collecting independent data first on the actual prevalence of OUD with its complexity at the population level. We should also look at data from all the agencies, including efficacy data from prison and community agencies, the recidivism rates, data from NAMS on the effectiveness of its detoxification and relapse prevention programs. When we sit together and analyze the above data holistically, it will give us an idea on how big or small is the heroin addiction related public health problem in our country in comparison with much bigger countries. It will give us an idea on whether the existing abstinence-based programs are sufficient or not. It will also give us an idea on the gaps in our existing treatment models in achieving meaningful recovery and whether that can be addressed by other evidence-based approaches such as OST. And so more honest debate and discussions are needed. And I would say we should consider embarking soon on a major academic exercise between all the relevant stakeholders to answer these questions. Meanwhile, I would strongly emphasize that we should establish much wider and seamless coordination between all the stakeholders to improve the effectiveness of our existing abstinence-based programs in our country. And the citations of the articles that I looked at for my presentation are in the next slide. Thanks for listening.
Thank you, Dr. Kandasamy, for your insightful presentation. Indeed, the issue with substance dependence, not limited to just opioids, is a complex one, and we do need more scientific evidence from multiple approaches in treatment modality to understand and address the issue. I also definitely agree with Dr. Kandasamy's call to wider and more seamless coordination between various parties to improve the effectiveness of our existing programs. Thank you once again, Dr. Kandasamy, for your sharing. So next up, the next presentation we have is by Ms. Teo Kashun from the Central Narcotics Bureau. So Ms. Teo has been working with CNB, Central Narcotics Bureau, Psychology Unit since graduating from Nanyang Technological University in 2017, first as a research analyst, then as a psychologist. Her job scope includes conducting psychological assessments, training officers, executing, monitoring, and evaluating implementations, as well as counseling. Her research interest lies mainly in drug policies and prevention. Her talk today is on examining the changing roles of narcotics officers in community supervision. With the introduction of more engagement in community supervision of drug supervisees, new identities and roles have to be adapted by the Bureau's officers. Therefore, Ms. Teo will share on a different perspective towards the shift in identity through the officers' experiences. Right, Ms. Teo, please.
Hi everyone, I'm Kashun, a psychologist with Central Narcotics Bureau, Ministry of Home Affairs, Singapore, and I will be sharing with you, on behalf of my team, our project on examining changing roles of narcotics officers in community supervision. Before I talk about the study, I would like to introduce my small but very strong team to you, Central Narcotics Bureau Psychology Unit. We were established in 2010 with just a psychologist, and 12 years down the road, we have expanded to 8 psychologists with some temporary staff. Despite our size, it hasn't stopped us from doing important work in supporting operational and organizational work, as well as drug research to support our policies. Most importantly, it also hasn't stopped us from having fun as a team. Moving on to the study, this is the scope of my presentation. So traditionally in CNB, our drug supervisees used to report for urine supervision mainly for detection purposes. But evidence suggests that supervision has provided positive assistance to reduce drug misuse and reduce recidivism outcomes. Therefore, as part of our demand reduction strategy of drug harm prevention, CNB piloted structured engagement with our drug supervisees that are conducted by our officers called Community Supervision Skills Sessions, COSS, in 2019. Officers are therefore required to take on new roles and skills, and hence it is important for us to understand their experience in these roles and lessons in change management. Our aim is to understand the supervision officer's perception of their changing role and the organization's support in CNB supervision process. We would like to know, how have the narratives of the supervision officers towards their new role changed? What were the organization's support to facilitate supervision officers into their new role? In order to do so, we have two theoretical frameworks. Firstly, in order to understand how their experience have changed, we use the change curve, that is an adaptation of Perman and Tackett's phases of organization change, which in itself is adapted from Kübler-Ross's grief cycle. Next, to understand more macro processes that facilitate organizational change, we use McKinsey's 7S model, a tool that analyzes elements in the organizational design that facilitate change. Using the framework analysis, we triangulate data from non-supervision officers' narratives, supervisees' experience, as well as management's perception against supervision officers' narratives across time. In 2021, we conducted a bureau-wide survey on officers' readiness towards the change. And, in general, we found that respondents who have not conducted COSS recognize the importance of supporting supervisees and addressing reintegration needs across job levels. However, they were anxious over the potential loss of identity and uncertainty in role. Ground officers were uncertain about the change. Those with supervisory roles were more cautious. And on the other hand, middle management were uncertain, but were able to recognize the bigger purpose of change. In our first research question, we examined supervision officers' narratives at 3 time points using Perman and Tackett's model, from shock to integration. Before implementation, respondents were shocked and were skeptical about receptivity and effectiveness, as they felt that supervisees may not open up to them because they are officers. They also had potential concerns about workload. Moving on to the first year, respondents were still skeptical about their effectiveness and started bargaining for their scope of work. They wanted to solely focus on engaging supervisees without other roles like administration. They also had difficulties adapting to the new role, as they were still trying to adjust to the new job scope and were also reminiscent of their previous role as an officer doing operations. However, we see that respondents have gained better acceptance towards their role as a supervision officer and also recognized the value in supporting supervisees. They also started to give feedback to the system for improvements. Beyond that, some of them have also embraced their roles as they express desire and happiness in being able to support supervisees. Some of them are even doing duties that are beyond their work roles, like helping supervisees to communicate with their family members. In the second year of implementation, we found that officers were not just giving feedback for the efficiency of the system, but they were also giving feedback on how to better support supervisees. Apart from embracing supervisees, they were also able to recognize the greater purpose of change. Beyond taking initiative to support their supervisees, they were also supporting each other by creating a positive work environment. With more perceived ownership, we also observed that respondents had desire for more involvement by having their operational experience considered and being able to define their specialization. This is consistent with literature that suggests that psychological ownership is positively associated with employees' participation in decision-making. Consequently, respondents were also feeling constrained to their limitations where they accepted reality and felt constrained about their ability to control supervisee's outcomes. Contrary to officers' beliefs on their limitations, over 80% of the supervisees were satisfied with the sessions and found them useful. They reported having better direction in life and learned skills like thinking about consequences. They also reported more practical help from officers and from referrals. Overall, we see that superficial officers gradually identified with their roles across time. Initially, they did not identify with the work. Later, they understood their role but had limited identification. Finally, they were able to recognize the greater purpose behind supervision. Overall, supervision officers were also more adapted in their roles across time, but they were feeling constrained with more expectations that comes with more ownership to their roles. Supervision officers embraced the change over the years by first taking active ownership of their work and culture, by experimenting in giving feedback and taking initiative in improving the work environment. Next, having a change in their attitude where they had more positive shifts in their interactions with supervisees by becoming more empathetic towards them. Lastly, by being more accepting of their new identity through embracing the role and going beyond that role. With more ownership, their concerns perpetuated, like their desire for role specialization, their perceived limitations in helping supervisees, and also their desire for more stake in decision making. The first learning point for organizational change is to have a work environment that supports active ownership, positive attitude, and acceptance of identity through continual empowerment and engagement. Next, it is also to acknowledge that certain concerns require time by acknowledging them through providing alternative solutions. Moving on to the next research question, we explore the type of organizational support to facilitate supervision officers into their new roles. We examine narratives at 3 time points and also applied McKinsey's 7S model to identify gaps and areas for improvement to facilitate organizational change. In terms of systems, staff initially reported high workload and multiple duties. Therefore, management took actions like better staff deployment by more effective scheduling and caseload management, which the supervision officers perceived better support from management in workload. More arrangements in staff deployment, especially for certain demographics, are in progress. Next, for strictures, officers reported delayed and changing processes at the beginning, which the management created a manual for standard operating procedures for supervision. They have also prioritized certain work. This has resulted in perceived faster and clearer processes for the supervision officers. There were initially insufficient logistical support as well, which were addressed from procurement and setup of rooms and equipment. Now, officers report that they have sufficient logistics like rooms to use for their sessions. In terms of skills, supervision officers reported barriers and difficulties in managing supervisees at the beginning. They also reported limited applications of skills. Therefore, we conducted refreshers and more coaching based on their top challenges. At 2 years, they perceived better ability to manage supervisees. Next, officers initially had worries about progression and recognition. They also expressed that they were more interested in other job roles. Therefore, the job functions were later defined a new batch of supervision officers was selected by interest. While staff progression is still in progress, we do see a motivated new batch of supervision officers. Overall, we notice the challenges are dynamic across time, and while we observe success in areas like work instructions, infrastructure, and skills, we also observe that challenges changes due to external conditions and identification of roles, as addressed in the previous research question. And certain challenges are also persistent due to overall structures, the need for time, and limitations that are beyond officers or the organization's control. Finally, many of the elements are interdependent on each other, like how communications affect workload and processes, but it can also help with staff motivation. And on the other hand, staff can also be affected by other factors like workload and work processes. Based on this research question, we have 3 learning points. The first learning point is that support needs to be an iterative process to cater for changing challenges. And therefore, continual understanding of needs between management and employees is very important. Next, challenges take time to adapt and solve, and therefore interim support like partnership to solve bigger issues is required. And finally, challenges are interlinked with one another, and therefore targeting root causes is key. These are my references, and I've come to the end of my presentation. Thank you for your attention.
Thank you, Ms. Teo, for the insightful presentation and how the officers and the Bureau as a whole actually evolved and changed to meet the expanded job scope due to COSS sessions and associated challenges. This is a very important step in helping our drug offenders stay on track. Thank you once again, Ms. Teo. The next presentation we have is by Dr. Adam Wee from the National Council of Social Service. Dr. Wee is Assistant Director and Senior Research Specialist at the Translational Social Research Division at the National Council of Social Service. He obtained his PhD in psychology from Nanyang Technological University and worked previously as a postdoctoral fellow at the Singapore University of Technology and Design. He has published extensively on human cognition early in his career and is now focused on research on child welfare and youth offending. So Dr. Wee's talk today is on cumulative childhood adversities and substance use in young offenders. So adverse childhood experiences, or ACE, are associated with worse outcomes in delinquency and substance use. And Dr. Wee's study contributes a local perspective on the relationship between ACE and substance use in Singapore young offenders using a longitudinal design. Without further ado, let's go to Dr. Wee's presentation.
Good afternoon, esteemed colleagues and fellow ACOP participants. My name is Adam from the National Council of Social Service, Translational Social Research Division. I'm delighted to be here with you to share findings on adverse childhood experiences and its relationship with substance use in young offenders. Now, throughout the whole presentation, I'll be calling adverse childhood experiences as ACEs, and that's how it's commonly called in the research literature. ACEs are defined as sources of intense and often occurring events in childhood that have profound impact in later life. These ACEs may include things such as physical and sexual abuse, neglect, and other forms of disadvantages like family violence or even parental incarceration. And as it turns out, ACEs are also very common, not just in young offenders, but also in the general population, with at least 2 in 5 reporting at least one episode of ACE in their childhood. In non-offenders and offenders, it has been shown to have more severe later life outcomes, such as higher likelihood of mental health problems. In young offenders, they also tend to offend earlier and also have a higher likelihood of reoffending and substance use. Importantly, however, ACEs take on a cumulative effect. such that when more ACEs occur, the outcome tends to be worse. This is known as cumulative risk. For example, when there are more ACEs, there is also a higher risk of reoffending, psychiatric and more serious substance use problems. What we wish to demonstrate in this presentation is to show the link between cumulative ACE and substance use. We also wish to examine the relationship between substance use onset and substance dependence problems. More specifically, these are our study hypotheses. First, we predict that youth offenders who smoke, drink, or take drugs have more cumulative ACEs than those who do not. 2 is to show that more adversities are linked to younger substance use initiation. 3 is to show that those who take substances earlier also tend to have greater substance use dependency problems. Our findings for this presentation were drawn from a 10-wave longitudinal study on youths called Enhancing Positive Outcomes in Youth and the Community, or EPIC for short. Our inclusion criteria are youths who offended between 2016 to 2018, between the ages of 11 to 19. Now in the EPIC study, we studied trajectories of offending and delinquent behavior with the aim to translate findings to policy and operations, to crime prevention and enhanced rehabilitation efforts. Now of course, with our large data set and longitudinal tracking, we are also able to look deeply at other delinquent behaviors and examine what sustains rehabilitation and desistance, and long-term outcome differences between offenders and non-offenders. These are our data collection methods, and the one highlighted in red are how the data are gathered for this presentation today. What you are seeing from the presentation here are only for the interviews with youths using psychometric questionnaires. We also interview caregivers and perform administrative data linkage with different government agencies. We also code the case files from youth offenders, and we wish to acknowledge the many agencies that have helped us in this study since its inception. Data in this presentation comprise 2 out of 3 cohorts of our young offenders, making up 790 young offenders in total. The majority of the participants are boys with an average age of about 17. As you can see, the majority of them were sentenced to serve community sentences such as probations when we first recruited them. A number of them were also sentenced to serve drug rehabilitation as well as institutional sentences. These were the main psychometric measures that were used for today's sharing. Substance use measures taken from the Drug Abuse Screening Test and the Michigan Brief Alcohol Screening Test. On ACEs, data was self-reported through the ACE-IQ from the World Health Organization and is freely available. The ACE-IQ is a well-cited instrument that assesses different ACEs such as physical and sexual abuse, neglect, and also parental separation due to divorce and incarceration. What we did to derive the cumulative ACE score is to total up the number of types of ACEs that are self-reported by the respondents. We showed that in our first hypothesis that there is a link between substance use and ACEs. As you can see, those who reported drinking and taking drugs have a higher number of ACEs relative to those who did not drink and take drugs, respectively. We did not see such an effect on those who smoke. We speculate that this is primarily because the majority of our participants smoke. Hence, there is little variability between those who smoke and those who do not in terms of the number of ACEs experienced. For our second hypothesis, we examined substance use onset age by performing a latent profile analysis to classify 3 groups based on when they started to take tobacco, alcohol, and drugs. Based on fit indices and interpretability, a 3-class solution was fitted, namely childhood onset, early teen onset, and mid-teen onset groups, with a gradated increase of onset age in when these youths started taking substances. From our latent profile analysis, you can see that the childhood onset group started taking different substances by about 2 years on average, younger than their early teen onset counterparts. Likewise, the mid-teen onset group also started taking substances about 2 years on average after the early teen group. Next, we showed that the childhood onset group having significantly more ACEs relative to the early teen group, which, in turn, they have more ACEs compared to the mid-teen group. This confirmed our prediction that those with more adversities tend to take substances earlier. Our third hypothesis was also confirmed, in showing that those who took substances at a younger age also having greater drug dependency problems, with the childhood onset group and early teen group having greater drug dependency problems relative to the later onset mid-teen group. In sum, our findings show a relationship between cumulative ACEs and likelihood of consuming alcohol and illicit drugs. Those with more ACEs also tend to start taking substances at a younger age. Moreover, those that started taking substances at a younger age also have greater drug dependency problems. There are a few reasons for this link between ACEs and substance use. Invoking the general strain theory, that when a child grows up in an adverse home environment, characterized by abuse and neglect, this may result in the development of antisocial and delinquent behaviors when there is frequent frustrations and anger, which then in turn leads to substance use. One complementary pathway may be through social learning, especially when the childhood adversities also involve parental criminal behavior such as substance abuse. At home, through modeling of adults, the negative perceptions of taking substances may also then be minimized. Based on self-medication hypothesis, growing up in these homes with multiple stresses may also then result in these youths turning to substances to alleviate distress and as a coping mechanism. From a neurobiological perspective, the lack of proper development and childhood adversity may also interfere with neurodevelopment of impulse control, making it harder to resist peer influences of substance abuse. Studies show that childhood adversities may also have profound impact on structural and functional brain development, which then in turn impacts on impulse control and executive functions. Now, we do not claim that any one pathway contributes to the link between ACEs and substance abuse. Rather, it is likely that these pathways, working in tandem, results in higher risk of substance abuse for children from these adverse environments. Regardless of the causal pathways, it does speak of the need for substance use prevention targeted at youths from disadvantaged backgrounds, especially in homes where there are ACEs. It may also point to the need for thorough screening of ACEs during intake interviews, as well as addressing them in the therapeutic context, especially when these youths may return to these environments after serving their sentences. Furthermore, what ACEs also tell us is that the home environment may be fractured, making it especially important to incorporate the family as targets for intervention and including them into the intervention plan. From a research and theoretical perspective, further research could look into assessing for chronicity of maltreatment to complement a simple cumulative ACE approach. What we have done here is a simple counting of the ACEs. While this is a very common approach in the research literature, we do realize that valuable information is masked, such as the type of ACEs experienced. From a resilience standpoint, moving forward, rather than looking at how ACEs causes deficits and harm to later development, we urge researchers to look into protective factors to see whether there are factors that protect you from taking substances despite being brought up in adverse home environments. With that thought, I'd like to bring a close to this presentation, and I thank you for your kind attention.
Thank you, Dr. Wee, for the study on the link between adverse childhood experiences and substance use. Indeed, this shows the need to focus on adverse childhood experiences, not just in treatment, but also in assessment and screening, as Dr. Wee has pointed out. This will help us to better understand how to prevent substance use from developing in individuals who experience ACE. Thank you once again, Dr. Wee. With that, we've come to the end of the presentations. And we'll now be moving on to the live Q&A segments for the remaining duration of the session. We would also like to invite all three presenters into the virtual space for the Q&A session. All right, we do have several questions for our presenters. I'd like to maybe get Dr. Kandasamy to kickstart. Question? Yeah. All right. The question for Dr. Kandasamy actually. So just now you spoke a lot about individuals with opioid addictions. So based on your own experience, are there differences in approaches or strategy for different types of substances? Like for example, let's say if it's not opioid, it's other kinds of substances. Do we approach it differently, or do you have a different strategy for it?
Okay. Yeah. I think when it comes to the whole spectrum of treatments available for substance use disorder, the main actually pharmacological treatment interventions are mainly for the opioid use disorder. The rest of the drugs, for example, for methamphetamine addiction or cannabis addiction or any other individual drugs, hallucinogens, at the moment, although here and there research is actually emerging to find some efficacy with some particular form of pharmacological treatment, but overall, there isn't any significant evidence when it comes to medically treating them. Most of the interventions for the rest of the drugs are mainly based on psychosocial interventions or abstinence-based interventions compared to heroin use. So the main approach actually is pretty simple. For heroin use worldwide is because of its chronicity, because of the individual countries having their own range of problems and the volume of problems that they face, with we're talking about thousands of people compared to the number of people that we might be seeing in our own country. So when they looked at overall approaches, they found the medication-assisted approach is the most meaningful and most cost-effective, which is why they went on harmony medication approach, particularly based on OST treatment for heroin use. So to summarize, the rest of the substance use disorder treatments, almost all of them are psychosocial intervention based.
Thank you, Dr. Kandi, for the answer. Yeah, just now I think you also mentioned towards the end of your presentation, there's really a need for different parties to come together, right, to really improve the current structure of the system. So from your experience, right, which are the parties that we need to come together to talk and to engage with each other?
All of us, actually. Right, you have a big research team, a psychologist team there, looking at all kinds of operational, organizational, various forms of research there to find out what's happening inside the the legal system. And there is a huge data there from the community in terms of what our halfway houses are doing, what other voluntary welfare organizations are doing, what Ministry of Home Affairs doing in terms of rehabilitation, and what is the long-term follow-up, what happens to people actually after SCORE actually provides the rehabilitation after the release from prison, what happens after 6 to 8 months, how often they remain in abstinence, or what is the lapse rate. So we need to look at all those data. Currently we all have our own data, but we work mostly in silos. I think I know what's happening with my own patients at NAMS, but I may not know the full picture of what is happening outside, in the rehabilitation circle, the environment, also within the legal system as well. We all know that, recidivism is pretty high, and mostly people actually go through several cycles of treatment, incarceration, rehabilitation before they really finally actually make 100% of full recovery. So we need to actually look at all these parties coming together, have a proper debate and discussion, and to find out more meaningful ways of how to work together first in terms of making it more seamless approach between all the agencies together, and also look at the data independently. Perhaps we need to also look at maybe an epidemiological survey of what is the substance use disorder rates in our population actually from an epidemiological point of view. So all this data will give us an idea, and based on that we can actually look at improving the existing treatment services in a more structured way, in a more meaningful to achieve more meaningful outcomes as well for our patients.
Thank you, Dr. Kandi. Drug use is really a multi-pronged approach, right? Regarding like multi-helping hands to come together. That's why ACOP is a good opportunity for us to make friends, and really later on, we can always work together to study something together. All right,
Yeah,
thank you, Dr.
definitely. I
Kandi.
would like to actually thank you for inviting me for that. Definitely.
Welcome. Thank you. And so glad you could join us once again. Thank you so much. Yeah. I think we have some, moving on, we have some questions for Dr. Wee. Yeah, I think a question, I think a participant was curious about the parents, right? The AC of the parents in the study that you shared. Could you let us know a bit more?
Yeah, well, thanks for that question. We do have the data on the parents, but it's not something we analyzed yet. It's something that's in the works that we will look at. But if you look at the existing literature, it's very, very clear that childhood adversities are actually intergenerational in nature. What do I mean by that? It's that when we see somebody having a childhood adversity, for example, maltreatment, abuse, and all that kind of thing, that it goes back several generations. Like the parents also tend to have it. Well, we haven't looked at the data in our data set, but I wouldn't be surprised that's something that we will see as well. Yeah, especially things like, because we also measure things like whether the youth actually rate their parents, whether they have been incarcerated before, whether there's any substance use at home. A lot of these different ACEs by themselves tend to be intergenerational as well. Yeah, so yes, it is a point of interest, but if you look at the literature, it's quite clear that it's intergenerational in nature. Yeah, I saw another question there in the chat, whether the findings will hold true for female youth. So I jump ahead. Just a disclaimer that our youth offender sample is mainly skewed towards males, right? So there are more males in the sample. But when we look at the literature, we also know that the effects of ACEs tend to be quite different from males and females. Yeah, but from our study, what we can see very, very clearly is that it's overwhelmingly males. So it may not be a very fair a split and look at the data. Yeah, but well, we note that and this may be something that we will look at as well. Yeah, albeit the skewed nature of it. Yeah.
Thank you, Dr. Wee. So just a follow-up question from the earlier point that AC is rather intergenerational in nature, right? So from maybe a treatment perspective, what should we start working on? Should we start working on the ACE or should we work on the substance use? Because both are quite deep-seated. Yeah, so from a treatment perspective, which aspect should we start working on first?
Well, this is my personal opinion. It has to be both. I think first of all, it's very important. And I think there's this whole point about family being a very, very important aspect of the reintegration and rehabilitation back to society. So you can imagine also if you're just working with the child and with the youth, and the youth is released from custody, for example, and goes back home, but the home is still in a mess. Where still have things happening back home. It certainly is not a very, very optimal rehabilitation setting. So in that sense, not only do you have to work with the youth in terms of the substance use and all that thing, but the family should also be incorporated in any intervention as well. So it's not really a priority of which one, but rather both, if the resources allow, of course.
Thank you very much. Thank you for the sharing. Yeah. Maybe we move on to one question for Ms. Teo. Yeah. So as a psychologist yourself who is actively involved in the COSS sessions, right? What is your biggest challenge or takeaway from conducting the sessions? Because it is really an expansion in scope for the officers, right? It's really a mindset change. And so what's your biggest takeaway or challenge in running those sessions?
Thank you for the question. So my role mainly as a psychologist is to train the officers as well as to evaluate the process. So I think it has been about 2 years plus coming into really implementation of COSS. So I think the biggest takeaway is really being patient with the process, because I think it is a rather huge endeavor for our organization, and it is actually a pretty big change for our officers as well in terms of the roles that they take on, as well as our organizational identity. So it is very important for us to be patient, to slowly begin at where our officers are at by allowing them to see the importance of supervision, even though there's no
it's hard, when it's new, it's hard to see the effectiveness of a program. So it is really being, patient and just listening to their challenges and addressing it one at a time. Yeah.
Thank you, Ms. Teo. Yeah, it does sound like a very meaningful experience for you as well. Yeah, we need to see the officers change and evolve in their job scope. Thank you very much once again. Yeah. So thank you to all my presenters. Thank you, everyone. We have come to the end of the Q&A session. I would just like to invite everyone to join me to thank the presenters for sharing their insights and research and perspective. And I'm sure myself included, all of us have gained much insight into the issue of drug harm prevention during the session. Thank you very much once again. Thank you.